Good evening. I'm Dean Don Moss, and I see familiar names so far among the attendees. Welcome to a webinar of the College of Integrative Medicine and Health Sciences for Saybrook University. Our topic is a look at current outcomes of the Affordable Care Act for Integrative Medicine and Healthcare. We have two presenters this evening, and they will give a kind of a tag team presentation going back and forth, sharing perspectives in a number of areas of the Affordable Care Act and the impact it's having on healthcare. Logistically, we had to use GoToWebinar because we expected more than 25 persons, and there are many more than 25 registered. The only disadvantage of GoToWebinar is that the audience is muted, so if you have questions or comments that you want us to share, please put them in the chat box, not the question box, but the chat box, and I will monitor the chat box throughout the presentation, and periodically we will stop for discussion, and at that point I will read the questions and comments to our two presenters. Well, thank you for joining us this evening. Our first presenter is Dr. Luann Fortune, who is the Director of Instructional Excellence and Director of the PhD Practice Specialization and PhD Healthcare Systems Specialization in our college. She teaches research courses, systems courses, mentors individual students, and supervises research. She has extensive background in management in the private sector, owned and operated a private practice delivering wellness consultation, educational services, and consulting to businesses and individuals in the Washington, D.C. area. Her research focuses on holistic aspects of massage and alternative and complementary wellness practices, as well as somatic awareness and embodiment techniques for scholarship, research, and practice. Her writings and publications span many disciplines, draw on systems thinking, and promote translational value for scholarship and practice. Many of you saw the blog about this webinar. If you didn't, go to the blog on the Saybrook forum, and the blog also has a URL to her website. Our second presenter is Lindsay Johnson Chang. Lindsay, unfortunately, has a technical problem tonight, so you're looking at her picture rather than a live webcam, but she does have audio and will be presenting. Lindsay is a second-year doctoral student in the Healthcare Systems Specialization. She works for VOX Telehealth as Vice President of Program Management, where she develops online platforms to enhance patient engagement, education, and compliance in high-cost areas such as orthopedic surgery and also palliative care. She has master's and bachelor's degrees in biomedical engineering from UT Austin, that's Texas, and Duke. She spent 10 years in the medical devices industry making implants for cartilage repair and bone regeneration. She's interested now in developing tools to help transform healthcare. She lives in Austin with her husband Joseph and her puppy Chloe. Well, that's enough introduction. I'm going to turn over to our two presenters, and Luann, go ahead and put up the PowerPoints.
Great, Don. Thank you very much, and thank you all for being with us this evening. I am fumbling just here a little bit because I am running the slides for our presentation tonight. So I'm going to start out a little bit, and I'd like to give everybody an introduction as to how it is we came to be with you tonight. So again, thank you for being here. As Don mentioned, I teach systems classes in healthcare for our MBM students. Are in the College of Integrative Medicine and Health Sciences. I also have a practice background, and I have a background in management. I'm very intrigued by the systems aspects of what's gone on with integrative health over the last 2 decades, but in particular the movement that is taking so much power right now. I teach a class called Complexity and Integrative, and its impact on integrative healthcare, and we focus on the Affordable Care Act in that particular course. Lindsay's one of my doctoral students, my doctoral student colleagues, and in our last class, which we conducted together, we did together in this past semester, Lindsay and I delved into, well, what has actually happened in the last couple of years in the implementation of the Affordable Care Act. We hear so much about the controversy over Obamacare that we forget that this has been the law of the land now for a little while, and we can actually step back and see what some of the measurable outcomes are. Now, by way of our introduction, neither Lindsay nor I are Washington or state level policymakers. We are in the academic realm, and we've taken a look at this question from an academic perspective. We have attempted to collect data from different sources and to take a synthesized scholarly view of this problem. But we're working together on this as a project, so there might be some questions having to do with regulatory specifics or details that we won't be able to address, but we look forward to this conversation in a collaborative way, sort of like a salon would be. The other thing that we find really exciting, and I do in particular about this, is that systems work in integrative healthcare, and in particular the program that we offer at the College of Integrative Medicine has an action research component to it. And by joining us tonight, you're all participating with us in surfacing the questions and the concerns that are going on around this topic, which has become highly publicized and also politicized. So what we're hoping to do tonight is, we've done our welcome piece. I would then like to offer an overview of the Affordable Care Act. Before we even came to looking at the outcomes, as scholars, we needed to go back and take a little historical view and do a summary on what the problem was that brought us to today and the state that we're in right now. Then, in interest of being mindful around this question, which is a systems question, I'm going to hand off the presentation power to Lindsay, and she's going to tell us what she found when she delved into looking at the outcomes. Where are we today in terms of what we can measure associated with the implementation of the Affordable Health Care Act? Then she's going to hand it back to me, and I want to talk about the Affordable Health Care Act and opportunities for integrative healthcare practice, because there are provisions in the ACA that offer opportunities for integrative healthcare practitioners and to the work that many of us do together. As Don mentioned, I have been in the practice realm. I do consider myself an integrative healthcare practitioner, but today I come to you as a scholar and trying to take an objective, very didactic approach to this question. We're going to have time at the end for questions and answers, but we also want to integrate questions as we go through this, and as I've mentioned, Don will be monitoring the chat box for us. So if you have not yet located it on your screen panel, please find it now, make yourself friendly with it, and please contribute questions to this. I wish we could have a verbal vocal dialogue, but we will do our best to address your questions as they come to us. So where I want to start is to take everybody back a few years and what brought us to the point of the U.S. healthcare system being problematic. You wouldn't have to pick up a newspaper or turn on CNN to know that healthcare expenditures have been a major concern of our economy, of our regulators, our policymakers, and every family in the United States for some time. The Census Bureau collected data on this, and in 2012 they reported an estimated $2.5 trillion in healthcare costs, and the projection on that was that it would be annualized to $3.5 trillion by 2016. Furthermore, 83% of the health care dollars were going to treat chronic conditions, and that data comes from the CDC. Now, what do they mean by chronic conditions? Well, they're really the top 5, but they have to do with the ones you're pretty familiar with. They have to do with cardiac conditions, they have to do with diabetes, and an increasing number of mood disorders that we associate with stress, and also with behavioral issues having to do with obesity and smoking. So what policymakers, as well as anybody who was reading the press, could observe was there was a trend upward, and from 1999 to 2010, chronic conditions were on an increase. So the chronic conditions that were adding to 83% of the healthcare dollars were increasing. Over that period of a little more than 10 years, they went from 16 to 21% for the age group between 45 and 64. And the increase from 35 to 49% on those over 65. Now, you also don't have to be a deep mathematician to appreciate that we are all aging, and that the baby boomers present a bubble of a generation moving ahead that will propel over the 65 and into the 85-year age range very shortly. So as the baby boomers reach the age of 65 and older, the Medicareable age, this problem of chronic condition treatment became even more pronounced. This is important because the projected increase of 42% over the next decade was not only based on a growing number of people turning 65 and older, but also an age expectancy, a life expectancy that was expanding all the time. When we look at the outcomes of what has happened with the Affordable Health Care Act, as well as predictions as what would have happened without it, one of the things we need to remember is that the population is not stable. And what could have happened over time without the Affordable Health Care Act is based on actuary numbers, remembering that we're an aging population that was increasingly riddled with chronic conditions, that were increasing health care dollars, and that we were living a lot longer. The bottom line was that policymakers, as well as head of families who were trying to run a budget, understood that we had to stem crisis-based and chronic condition-related costs. There was also a bigger problem associated with this. To stem those chronic problems, we needed preventive programs and services. They were key to be able to address chronic conditions. So we're all familiar with preventive medicine and how preventative is one of the key ideas and concepts involved in integrative medicine, integrative wellness, where we're not just simply treating pathologies, but we're also generating a better, a weller way of being in our bodies and in our communities. However, this was the problem. In 2010, which was only a mere 5 years ago, record numbers of Americans were uninsured. And they were primarily into three groups. First of all, there were the youth of our country. And by youth, I can now say anyone who is under 26 could be counted in that group because they become an important demographic group. Also, those with pre-existing conditions were not able to get insurance coverage that would have helped with some of the crisis management of the conditions that they're experiencing. The other group had to do with people who were self-employed, unemployed, and underemployed. And those were important key groups that were not covered under any health insurance. So out of this came, from the policymakers, something that's called the triple mandate. The triple mandate is this. First of all, that patient experience should be enhanced by switching over the paradigm in which medicine is practiced to a patient-centered care model that focused not just on pathology but on wellness and preventative medicine to stem the raising costs of chronic conditions as well as to enhance the overall patient experience. This is not a small thing. This is, as we well know, a very large thing, and it's also key to integrative medical practices. So it's important for me to mention right now something that's not on the screen, but I will assume that much of our attendees tonight can appreciate this. When we talk about integrative medicine and integrative wellness, we are not simply talking about the introduction of what used to be called complementary and alternative practices. We're not simply talking about taking massage therapy or acupuncture or chiropractic and fitting them into a model that delivers certain services on a menu basis. We are actually talking about shifting the paradigm so that instead of just offering services in the same way we did before, we actually change the focus, and that the patient and their wellness becomes the focus going forward. rather simply than service delivery to stem pathology. So that's our point number one. The second point was to improve the health of the population, and Lindsay's going to talk a little bit about this tonight, but this is an incredibly important point. One of the fallacies that we think exist in popular media is that the U.S. healthcare system is the greatest in the world, so why would we want to change that? Lindsay's going to show you data tonight which hopes to dispel the almost mythic proportion about the idea that the U.S. system already was the best healthcare system in the world. Why would we want to change that? The third thing has to do with the reduction of per capita cost. So I spoke earlier about the chronic condition. One of the problems related to chronic conditions is also extended to the way we deliver medical systems. And you will see some data on that that demonstrate that a disproportionate amount of the healthcare dollar is spent on episodic medical crises. Some of these are projected to have been avoided simply by dealing with prevention to begin with. We've all heard the stories about the asthma attack that ends up in the emergency room at a much greater cost to the individual who's experiencing it as well as the system that is providing that, when it could have been prevented simply by having a canister of albuterol ahead of time. So one of the main goals here was to stem the costs linked to episodic medical crisis. The other important part is projections of increased costs for aging populations need to be dealt with in a more intelligent and humanistic way. And as a little aside, I did a study last year that was an in-depth phenomenological study having to do with medicalized aging that explored exactly that. If any of you later want to contact me about it, please do. I'm happy to talk about that. That's probably a different webinar. Or you can simply Google medicalized aging and you can see what we're talking about. The third bullet point here is to address the shortage in primary care systems, and that has been a disproportionate problem in the community and across our nation. So at this point, I'm going to hand this over to Lindsay because she's going to talk to you about what happened from 2012 onward. What I've done, hopefully up to this point, is to set the stage as to why we had the Affordable Care Act to begin with. So, Lindsay, are you with me?
I am here. Can you hear me?
I am. And give me just a second, please, while I switch my slides around. And excuse me, folks, I took your screen down for just a second so you wouldn't see me fumbling here in the background. And I am now back up once again, and I am on slide number 1. So, Lindsay, I am now on your title page. I hand this over to you, and I'll take down my camera. It's all yours.
Okay, great. Okay. Well, thank you, and thanks everyone for being here. I feel pretty honored to be able to present alongside with Luann. I really appreciate the opportunity, and as she mentioned at the beginning, you know, I'm not at all an expert on the Affordable Care Act, but more of a from a mindset of curiosity, learning, synthesizing, and collaboration with all of you as well. So I'm definitely open to discussions during this and afterwards as well. Also, I'm not a politician, and I do understand this is a really political issue, but I'm coming at this from a neutral standpoint, more of a scientific and scholarly standpoint, as Luann mentioned, looking at what's going on and how does it work, and the fact that this is part of our laws and part of our system, and we might as well know about it and see if it can be useful in creating and understanding the new landscape of healthcare and how it's going. So, Luann, I'll let you go to slide 2. So, this came from the question of how does the U.S. rank actually in our healthcare system versus the other developed countries of the world? And this table it sort of shows you from the CommonwealthFund.org, from their article called Mirror Mirror, how the U.S. ranks on multiple different aspects. So there's several different pieces that they've looked at about the healthcare systems on the top 11 most developed countries. And as you can see, the dark blue is the 1s and 2s. Those are the ones that have the highest ranking for those various different. The UK's got several number ones there. And then the middle gray is kind of the middle of the road, and we actually do have several rankings in that middle gray area for the US. But the very light blue or gray, whichever one, however you see that, is kind of the low end, the 10s and 11s, and we have so many of those that we actually rank overall last in this group. And so that struck me as being really interesting, and I wondered what aspects of the Affordable Care Act, were developed to address some of these things, and is it working? And so my interest was to kind of take a look at this, maybe analyze it a little bit, and say, okay, what parts of the Affordable Care Act might help us improve our status in these different rankings. So maybe go to slide 3, Luann. So my initial thoughts on this were that we've got a decent ranking on quality, timeliness, effectiveness, and being patient-centered, and so that kind of told me personally that maybe we know we have some of the best doctors, some of the best technologies in the world, and a lot of these things are working well, or at least as well as the other developed nations. The process and the system, though, seems to be what's holding us back, from my personal opinion, looking at this, because where we find ourselves ranking low, and maybe even you could go back, Luann, to slide 2 just for a quick second, is in cost, efficiency, equity, and healthy lives. And healthy lives was actually defined in this as all the mortality amenable to medical care, so things that could have been treated or prevented, as well as infant mortality and life expectancy at age 60. So it kind of makes me think that coordination, safety, and you can go back to slide 3 now, maybe are some of our concerns, as well as cost. So looking at this, I'm thinking, okay, this is telling me that in order to become the best healthcare system in the world, to change all those 10s and 11s up to 1s and 2s, what we would have to do is increase our coordination, our safety, improve our equity of access, focus on creating overall well-being instead of just eliminating disease, and improving cost and payment structures. And that's kind of what my initial thoughts were, and so I was looking for those things in my digging about the ACA. So slide 4. Just as a quick review, and y'all are probably familiar with the Affordable Care Act, but this was signed into law March 23rd, 2010, and it has several major goals. One is to improve coverage options, and the way it does that is by requiring minimum essential coverage for all offered policies. This is especially important to me personally because I've noticed that, for example, in Texas, there is no private insurance I can purchase that covers pregnancy, for example. And the exchange, the Affordable Care Act, is the only way I can get insurance other than through an employer that would cover maternity. So that's really interesting. But anyway, so preventive services also would be improving coverage under the Affordable Care Act. So these are things like screening, women's health, and then there's also a provision about reimbursement for any licensed provider being required. So, if you're in a state where you're allowed to be licensed as a provider, the Affordable Care Act should allow for reimbursement. That doesn't mean that the policy you get has to put those providers in network versus out of network. So the reimbursement may or may not be complete, but at least there's movement in that direction. Second goal is to reduce the uninsured population, and the way that it does that, and this is actually partially because you're trying to offset the fact that they're going to have to cover more things, so you want to have more people in the pool, right, inside the insurance pool. One is that it requires all Americans to obtain the minimum essential coverage throughout the year, or they have to pay a monthly tax. So every month you don't have coverage, you have to pay a tax on that. And you probably all saw that last year if you did or didn't have an accountant asking you those questions. Also, it requires employers to offer plans with minimum essential coverage, or they can be penalized for that. So it changes sort of the offerings for employees at their employers. Also, it provides subsidies for low-income Americans through the exchange where they can get help in affording insurance, health insurance. It also expands Medicaid to cover the gap. There's a big gap between who's eligible for Medicaid and who can actually afford insurance. And so they're trying to close that gap, and what they did is expanded the Medicaid salary ranges in order to cover it a little bit. And then it also increases the age for dependent health insurance to 26 so that people with children can cover their children longer. And that also increases reduces the number of uninsured. So next slide, Luann. Another aim of the Affordable Care Act is to improve access to insurance, and it aims to do this through the marketplace, the exchange, which is the healthcare.gov website that has all of the plans by state that you can purchase. And one thing, I mean, I personally have actually gone through this journey. I am on the exchange. I have a policy from the exchange, and I noticed that what was nice about the marketplace is all of the forms for all the various different insurance policies that are available, like Blue Cross Blue Shield or United, et cetera. They all have the exact same format. You can look at like A versus B versus C on each item. They're in a row. They're right there. It's easy to compare. And I thought that was really a neat aspect of how they designed that exchange. Also, it improves patient rights. So it prohibits discrimination on pre-existing conditions or gender in order to be eligible for insurance. And it also prohibits rescission of insurance once you have it if you were to develop a condition, et cetera. So it improves ability to cover people who really need it. And then also there are provisions to encourage reform to cutting wasteful spending. One of these is related to Medicare. So CIMHS, the Center for Medicare and Medicaid Services, has a bundle payment program that's been in process and sort of expanding in various different directions over the last couple of years. Because of my job and what I do, I'm always looking for what's happening with orthopedic surgery. And one of the most recent expansions is the I think they call it the Comprehensive Care for Joint Replacement model. And this is something that CMS just recently put in place, and it's going to start, I believe, in January. It might be pushing out to April. But 75 geographic area hospitals in those areas will be forced to go to the bundled payment system for the orthopedic surgery DRGs. And what that does is that means that the hospital gets 1 month some payment from Medicare for that procedure that has to cover everything they're doing with that patient for a certain period of time, not just the procedure itself, but also what happens to them within 30 days after that. For example, if they end up going to skilled nursing facilities or using outpatient rehab, et cetera. So what it does is it promotes more coordination between those various different providers and trying to get the patients in and out without complications, without going to skilled nursing, et cetera. So it's actually, for my company, and just a personal example, it's a good thing because we're trying to help hospitals prepare patients for surgery and trying to help patients understand their role in making sure that they're ready to come home after surgery and recover at home, et cetera. So there's a lot of interesting reforms that are happening that are causing change in many different areas of the healthcare system that because of these sort of mandated procedures or programs that are coming down from the Affordable Care Act. So it's kind of trickling throughout, sprinkling throughout. And then also there's fraud reduction programs. I'm going to talk a little bit more about that later, but I was really shocked at what I found out about what's happening with healthcare fraud. So go ahead, Luann, to the next slide. So this is an example. I'm not going to go through all of these, but this is just an example of the 46 or more, I think there's actually more than 46 new entities that were called for or sort of initiated with the Affordable Care Act. and that includes the Center for Medicare and Medicaid Innovation. This is a place, a group that is the group that's coming up with these ideas of how to test different service delivery models, payment models. They're being funded with $10 billion every 10 years. So people are really interested in making this work. Also, another one to highlight is down the page there, the Preventive Services Task Force. I was really interested to find out about this task force and look at how they are actually going through the research and reviewing the evidence to try to make recommendations for what preventive services are actually effective in which conditions, and to publish those so that they can be used by providers and also by payers to understand what should be paid for. And as research continues, that this task force will be continuing to look for that and adding more and more things to that list. So that's another interesting one. And also the Patient-Centered Outcomes Research Institute. This one, maybe you all know about this one since it's more research related, but I found that this was kind of a really cool group of initiatives that's going on to improve the evidence on the prevention, diagnosis, treatment, and there's actually some particular focus on integrative methods. So I thought that was interesting. But there's over 46 that have been come out, so it's a lot. At this point, I'm going to change to kind of talking about what's been happening. Maybe I'll just ask if there are any questions right now on the chat box or in any other format.
There is a question, Lindsay, and I'm trying to get to it. Someone used the question box. Actually, there's a couple questions. I wish people would use the chat box, but unfortunately, it's very hard to read the ones in the question box. Okay, let me...
I can't see them at all, Don.
Yeah, I'm trying to enlarge that box. Okay. Just a moment. Isn't it true that whether or not Medicaid was expanded was ruled to be a states' rights issue? No, the question disappeared already.
That's true.
Okay, great.
Yes, that's true. And in fact, I'll be showing you the state map in a couple of slides coming up, so you'll see a little bit more about that. But yes, that is true. The Medicaid expansion has been given to states to choose.
Okay, Kristen, thanks you for the presentation. She's going to be able to stay for part of it. Oh, and then a couple of people noticed that I didn't mention their names, so I'm going to read the whole list of attendees again, and then I do see another question. Beverly Rubik, Bhaskar Banerjee, Chanel Hierman, all the way from New Zealand, I believe, Innocence Branch, Joanne Wright, Kanishka Agarwal, Karen Thompson, Kirsten Klinghammer, Kristen Jameson, Lisa Zaremsko, Noelia Leita, Pia Fontaine, and her hand is up, so I'll see in a minute what's going on with that. Rhonda Johnson, Ruth Ann Russo, Celine Vega, Tamami Shirai, Sabrina Epps, Carolyn Trasco, and Shannon McLean. Okay, so back to the questions.
While you're looking at the questions, I just want to thank everybody for joining us.
Oh, some of them are they're having trouble getting to the chat box. That's why they're using the question box.
Ah, okay. So I want to thank everybody though for being here, because even at this halfway point, and we're not even quite there yet, this is really exciting. I wish we could hear everybody.
Beverly Rubik is saying, if possible, to enlarge the slides, use slideshow mode. You're only showing the slide in a diminished form by doing it the way you're doing it, and it's hard for her to read the text. So if you hit show slideshow, do you know how to do that with PowerPoint? You're not actually showing the full screen slide. Okay, now we don't have you at all.
Luann?
Luann? Oh, yes, I'm here. I'm here. I took down my screen. I also ended up taking down my focal. You would think I don't know how to use my technology. Let me see if I can get myself out of here and display any difference.
Okay, lots of comments that people have to use the question box because the chat box isn't available to them, which is unfortunate because the question box is just teeny on my screen, so I'm trying to find a way to enlarge it. But anyway, I think that's all. There's several people thanking you and saying they can be here for part of the presentation. So go ahead.
Is the screen better?
Yeah, we can't see it just now. You have to put up.
Oh, thank you.
Show your screen.
Okay.
Yes.
Okay, good. Thank you.
Much better.
Okay, wonderful. Well, I wanted to be sure we addressed anybody who has had burning things. I'm glad we got all those issues addressed, so that's great. Thank you. Okay, so I guess I will continue unless, Luann, you had anything else at this point?
I won't, but I'm going to need to remind you that I can no longer see your slide numbers because of changing modes. So make sure that you tell me what the title is on the slide so I don't lose track.
Okay, no problem.
Thank you.
So I'm moving to slide 7, and it's titled, Has It Changed the Number of Uninsured? What I wanted to say, this is kind of one of the biggest questions that comes up with the Affordable Care Act is what is it doing and has it worked and what's happening? And I have two pieces of data. One is from June 2015. Since the marketplace opened in October 2013, those plans actually started January 1st of 2014. So there was kind of this preliminary period from early 2013 to October 2013 of preparation for the marketplace opening up, and then the policies are starting in January 2014. So that gives you some context. But as of June 2015, so that's 18 months after the policies started, there is a Gallup Healthways poll that was done showing that the reports of uninsured fell from 17.1% in late 2013, the Q4 of 2013, to 11.4% as of June 2015. And that's of the whole population. And so I think that represents maybe about, I want to say 10 million people, something like that. You can do the math, but it's a lot of people who've now got insurance. It continues to drop in most states. The largest drops, actually they did sort of a demographic breakdown, and the largest drops were seen in Hispanic population. We saw a 9.6% drop in uninsured. It's kind of a double negative there, drop in uninsured. African American population had an 8.9% drop in uninsured, and low-income Americans a 9.9% drop. There were no demographic subgroups that reported a rise in the uninsured population. So that's one set of data. Another set was recently released by the CDC, and they release this about every 6 months or so. The National Health Interview Survey from the CDC from June 2015 shows that the rates are down as far as 9%, meaning it fell from 17.1 down to 9. And that is 16.3 million fewer than 2013. So we're up to 16.3 million more people covered with insurance than before the Affordable Care Act. For adults less than 65 years old, now that's the non-Medicare population, so those are the ones who would most likely be affected by going from an uninsured to an insured status. That has decreased dramatically from 22% to 12.7% from 2010 down to today, or to Q2 of 2015. I'm sorry, it's not today. These rates are the lowest since 2010, so that's something to be said. And the next slide, Luann, shows a graph, and this graph is for the adults that are from 18 to 64 who were uninsured, and they were interviewed. This is part of the CDC data. And this just kind of gives a visual sense of what happens, like see how flat the lines are before you hit 2013, and then it starts to go down, 2014, down again in 2015. And that, it gives me at least some sense that, yeah, something is happening in this population. The next slide shows a map of the U.S., and this says state participation in the exchanges. This is a map showing which states are participating with exchanges of their own, the state-based, and which ones are defaulting to a federal exchange, and which ones are partnering from state to federal. And one interesting thing I found is that there's a statistic, this is actually from NPR, from the NPR website, but there's a statistic NPR reports that 59% of the uninsured are coming from the states where federal is the only option, meaning the state is not really participating. They're just taking on the federal exchange and offering that as the only thing. So that's kind of an interesting point, and it actually flows right into the next slide, which has to do with the Medicaid expansion. And I think someone brought this up as a really, really good point, which is for Medicaid expansion, this is actually something that was handed over to the states. They don't have to do it. They can choose to do it. And the statistic that came out, this is from November 2nd of this month, shows that 31 states have adopted this, including Washington, D.C. One state is in discussion, that's Utah, in the light blue there. And then 19 states have not adopted at all. And the Kaiser Foundation has some data showing that these blue states who've adopted saw a 9.3% drop in the below poverty uninsured rate, where the orange states that did not adopt only saw a 4.8% drop. Now both of them saw a drop, but it's a difference between whether you've expanded Medicaid or not for the poverty, below poverty insured. And then on the, I'm sorry, is there a question, Luann?
I was going to actually ask you to explain what the expansion meant, and I think maybe you did just do that. So,
oh yeah, this is increasing the salary numbers for eligibility for Medicaid. So it's actually increasing access to Medicaid coverage.
Right.
And then,
thank you.
Sure. Interesting, just another note, Arkansas and Kentucky apparently had the most significant drop, 13.4%, 11.4% overall the states. So that was just kind of an interesting fact. So did it effectively expand Medicaid? This is the next slide. So I just sort of explained all of this, I think, actually on the map. And one point I haven't explained is that there are some opinions out there, I think this was on the Gallup website, on the opinion that this expansion is kind of reaching its max, meaning the people who aren't going to do it aren't doing it, and the people who have already achieved the reduction in uninsured that would come from this expansion. So they don't really think that this is the way that's going to keep improving reducing the number of uninsured. So that would leave, purchasing of plans on the marketplace and the other abilities to afford insurance as the other ways to keep this going. So the next question is, has it reduced spending? So this is slide 12, and it's the interesting part about this is actually the answer is really no, it hasn't actually reduced spending, not yet. In 2009, the per capita spend on healthcare was $8,089. This comes from a website called Obamacare Facts, as well as Fierce Healthcare, which is a really cool website that sends out email facts on these kind of topics. And 2015, it's now at $9,000 per capita, so it's gone up a little bit. But the growth, that particular growth from 88.9 to 9,000 is much slower than it has been in the past. So the 2014 growth was the slowest since 1960. And this price inflation is at its lowest in 50 years. So that it is reducing the growth of spending. Also, this comes back to the fraud. There's a lot of work that's still needed to actually improve and reduce the amount of fraud going on with Medicare and Medicaid. There was a Governmental Accountability Office investigation held in June 2015 that looked at the top Medicaid user states, which is Arizona, Florida, Michigan, and New Jersey. And it found that $18.3 million was actually paid to the same person in 2 different states. So there's people who are actually pulling money that doesn't belong to them. Also, $9.6 million was paid out to 200 people who are already deceased, and $4.2 million was paid out to incarcerated persons. $2.8 million was paid to providers who did not have a license, was revoked. And in order to, stop this waste, the effort, this Governmental Accountability Office investigation is trying to say, put more effort into this and you can actually reduce your spending by $2.9 billion. That's a huge number. So it seems to me like that's definitely worth looking into. At least I felt shocked about that. Okay, the next slide, this is showing just a graphical example of what I was trying to say about the spending, where we actually are pretty much on track to what was projected. So the dotted line there is the March 2010 cost estimate. This is net budgetary effect of the Affordable Care Act. This is what they said was going to happen. And then there's a gray line for May 2013 and a darker line for April 2014 that shows we're actually performing this outcomes, performing pretty well on track. So that's kind of interesting as well. Okay, the next slide, this is about preventive services. So we've talked about budget, we've talked about uninsured. Is it helping with preventive services? So I talked a little bit earlier about the United States Preventive Services Task Force, and there's an interesting thing that they published, which is the rankings of all these different preventive services. For example, screening for depression, screening for diabetes, different types of screenings for cancer or HIV, etc. And they rank these screenings and counseling services with various letters. And if the ranking gets an A or a B, then that is something that would be considered for coverage. So that's just a really interesting place to go look to see what's happening with this. And I'd welcome anybody who knows more about that to contribute on the chat box or on the question box. Also, there's a group looking at routine immunizations and coverage for those, the flu shots, meningitis, tetanus, HPV, etc. And for children, there's the Bright Futures Project. This includes the immunizations and the screenings, but also more assessments for behavioral and developmental issues, nutritional concerns, autism, vision, etc. So you can see the list there. So that's a really interesting project going on from this. And with women's health, looking to see what should be covered that is going to really be helping people with like well-woman visits, FDA-approved contraceptives, screening and counseling for STDs, etc. And the last point on this is that there's a tracker, and you can actually go to the Kaiser Family Foundation website, the website listed there, and you can see the tracker of what's covered and how it keeps coming out with more things that are covered and more things that are covered. So I thought that was a really cool service that they're providing everyone for free. The next slide, I'm kind of going to shift gears a little bit now and go to discussing some of the protests about the Affordable Care Act and see what has happened relating to those protests or concerns. Are there any other questions at this point?
Yes, there are. Lisa Zaremski, who earlier made the comment about states and Medicaid, now she comments, if I remember correctly, oh, wait a minute. Many of the poorer states decided not to expand because funding for the expanded Medicaid was only guaranteed federal reimbursement for 4 years. Has the cost of medical expenditures per person in the U.S. gone down since the implementation? Well, you've probably already addressed that. Go ahead.
Mm-hmm. Right. Mm-hmm.
And she didn't. It didn't.
Right. No, it has not. Yeah, it has not gone down yet. That's a good point.
Mm-hmm. And if I can even add to this, if you've been paying attention to this in the press right now, there's some indication that the cost attached or associated with those who are privately insured in obtaining insurance, in other words, the cost of insurance premiums, is being shifted directly back to the individual. And I think Lindsay's going to talk about this next when she talks about her exploration into whether or not employers moved to a part-time sort of setup with their employees to avoid compliance. But I can mention that there is some good data now to indicate that companies that are employers who experienced an increase in premiums simply pass those back to individuals. So that also goes into those increased numbers. More questions?
Really good point.
Mm-hmm. More questions, Don?
No, that's it. Let me double check. Yeah.
Okay. And just in the interest of time, Don, how much time do we have left, just so that I can get a good sense of where to go from here?
We advertised this as ending at 10 o'clock Eastern, 7 o'clock Pacific.
It's 9:21 right now.
Right. So you have
Thank
roughly
you so much.
a little over a half hour.
Perfect. Okay. The rest of this won't take too long, and then we'll go back to Luann for some interesting points as well from the integrative medicine side. Okay, so from the political right, there were concerns about employers wanting to move everyone from full-time to part-time to avoid compliance with the Affordable Care Act. I'm going to talk about that a little bit. They were also concerned that current employees would lose their coverage, their existing coverage, because the employer could not meet the minimum essential coverage requirements. So I'll talk about that. They were concerned that it was illegal to subsidize for these federal plans because they were, this is not something that was allowable, and that it was unconstitutional to tax citizens if they didn't have coverage. Those two things went to the Supreme Court, as you all probably know. And then the reductions in the uninsured, they're concerned this was not enough to justify the extent and the effort that of the Affordable Care Act, and that's a judgment call. So the next thing, slide 16, which says, did it cause private sector employers to move everyone to part-time? Answer to that I found was not really. The part-time workers numbers actually fell between 2013 and 2014 by 230,000. And the full-time employment number grew by over 2 million in that same time period, anticipating the Affordable Care Act. Now there was reported, this is all from Ford, that some public sector workers did receive cuts in work hours. This is public sector workers, which is interesting, due in part to the obligations of the Affordable Care Act. So it did have some impact. Now the next slide, did some lose coverage from their employers?
Can I add on to that too? Because there's there have been some speculation, although it's difficult to know on a paired. You can't exactly run a paired t-test on this. So there's some indication that more and more workers opted to go to part-time because they were no longer reliant on their employers for health care because they had the option of going to the marketplace. So thanks for letting me add that.
Interesting. Yeah, great. So the next slide is about did some lose their coverage from their employers? And the answer to that is yes, that I could find. That some did lose their coverage, not due to not meeting minimum standards. This was 18.6% or 2.6 million lost existing coverage. However, the one place that redeems this a little bit, I guess, is that about 1.6 million of those people are actually eligible for subsidies on the exchange. So they could actually go to the exchange and get a better policy, one that meets the minimum standard for about the same price. But that still leaves 1 million that don't have coverage. They would have to find a policy on the exchange that will cost them more money. So that was what was reported by Forbes on this question. Then on the legal issues, these are the two issues about being illegal to provide subsidies. The Supreme Court said that's okay, and the state can choose. And then also is it unconstitutional to require everyone to obtain health insurance? The Supreme Court says it's allowable as a tax. It's not a mandate, but as a tax. So you don't have to go get health insurance, but if you don't get it, you'll be taxed. And it does let the states opt out of expanding Medicaid, which we talked about. The next slide, Luann, is called Attitudes in Public Polls. And this is a slide I pulled from the Kaiser Family Foundation. They've been tracking the public's views on the Affordable Care Act with the question that says, given what you know about the health reform law, do you have a generally favorable or generally unfavorable opinion of it? So that's the exact question that was asked. And you can just sort of see over time, it looks like this, that the landscape on this is changing quite a bit, although we're really close to half and half, even from way back to, this goes through October, I believe, of 2015. It's basically half and half, and it kind of has gone from mostly unfavorable down to, you know, kind of switching back and forth a little bit. But that's just a visual example of how this is moving just from the public's opinion. The next two slides, the first one says practitioner polls, are about physicians and healthcare workers, nurse practitioners, and physician's assistants. I thought it was interesting, this data from the Kaiser Family Foundation about how physicians and nurse practitioners report the increases in their Medicaid or newly insured patients. So this is them saying, yeah, I think I'm getting more patients. I think I'm getting more Medicaid patients, or I think I'm getting more patients who have been newly insured. It's, you know, there's some flaws, I guess, in that kind of questioning, but just showing for the sake of interest how this turns out. So it says 6 out of 10 primary care clinicians are seeing more Medicaid or newly insured patients since January 2014. So that's amount. And then the next slide shows an interesting point about whether this is really something that is the political influence more powerful than anything? And in the answer to the question for physicians, what is your opinion of the healthcare law that was passed in 2010, the Affordable Care Act? It's interesting that they're kind of split almost half and half into very favorable or unfavorable or favorable. But on political, if you look at political identification, the physicians who identify as Democrat are mostly on the favorable side, the physicians who identify as Republicans mostly on the unfavorable, and the independents are split. So it's kind of an interesting thing to see how that breaks down. So in close to closing here, I just want to revisit the original question, which was, can the Affordable Care Act help us improve our status in becoming the best healthcare system in the world? And the things we identified at the start were increasing coordination and safety. The Affordable Care Act does actually have support for the integrative health systems, which Luann's going to talk more about, and also promoting things like the bundled system, which increases coordination between providers as well as accountable care organizations. And the second one was improving equity of access. I think that has some room still to improve with increasing state participation if that can happen. But the Affordable Care Act did attempt to increase equity of access by focusing on equal patient rights on the Medicaid expansion and adding those up to 26 years old. Also, the third piece was focusing on creating overall well-being instead of just eliminating disease. The Affordable Care Act does address that with preventive services, patient-centered outcomes research, health promotion focus. That's mostly in the patient-centered outcomes research. But allowing for those new organizations to promote these things and come up with ways to prove that these are useful and they're helping people overall with their well-being. And then improving cost and payment structures. And this goes back to an Affordable Care Act that's come out with the mandates for insurance coverage, the subsidies, the minimum coverage rules, value-based payments, and the bundled system. So I think there are aspects of the Affordable Care Act that can help us with our 10s and 11s from that original graph. And that gives me a little bit of hope as well. So my last slide is about what can you do to help. And I was kind of inspired by this research, you know, looking at what's happening with the Affordable Care Act, because I personally didn't know that much about it. And I feel like I should, and I feel like we all should. And the one thing I think can help is increasing your awareness and helping others increase their awareness around you, your family, your friends, and help people you know, and be active in your local state government, because these issues are being decided at the state level, a lot of them. I put the websites here where I pulled a lot of this information, and you're welcome to check those out and make your own conclusions, and I'd love to hear those. And also, I think there's a lot of people who still don't really know about their options on the exchange. I personally have a policy on the exchange now, and I've been through that process. I think it was sort of an enlightening thing to go through and see how this can help people, and I really do think it can help people. But it may feel intimidating, or it may feel confusing if you don't know about it. Also, even physicians, I think, are still unaware that they can benefit from things like expanding Medicare, expanding the Medicare primary care benefit, and also Medicaid. And then finally, I found a place on the CMS website, and this is really for Medicare beneficiaries, but it's interesting to see from anyone's point of view what the different hospitals are charging for different procedures. And you can actually go to this website, and it shows hospital costs for Medicare beneficiaries by procedure type. And you can choose hospitals that are good quality, that show good quality metrics, but also are charging something reasonable. And that to me was kind of an interesting way to be a smart shopper for healthcare. So with that, maybe I can ask for one more round of if there are any questions, and then I'm going to pass it over to Luann to talk about the rest of the presentation.
Okay, here is a question. Trying to see who it's from. Oh, it's from Chanel Helgeson Herman. While I do not question your statistics, I know several people that saw their, oops, no, I'm reading the wrong one. Chanel just said had to go to a meeting. Thanks for a great webinar. This next one, I'm not, oh, Lisa Zaremski again. While I do not question your statistics, I know several people that saw their hours drop due to the insurance mandate for full-time employees. I know that almost no one working in the Walmarts in my area were given full-time. Almost everyone that wasn't management was limited to 39 hours without benefits.
Mm-hmm. Mm-hmm. That's really interesting. Yeah, that's a good point to make. And I'm sure that that's happening in various places. And, it also depends on the time frame, because I think the time frame I had on that was not as current as maybe what you're saying there too. I'm not sure, but yeah, it could be changing.
Well, and I think that an important thing here is we are working with numbers. So I think we've all got anecdotal stories about different situations where we've seen people who have had their hours cut. One of the most notorious was a couple of years ago, where the regents of the Board of Trustees of the University of Virginia University System voted to restrain and contain the number of hours that their adjuncts worked across the system in order to avoid having to offer them health care. And that was this was the University of Virginia system. It was a public vote. It is on record. So, of course, it became notorious. I think what Lindsay's numbers point to is that when you look at the aggregate overall, that the costs haven't changed that much, and that the point about part-time versus full-time, are people offered insurance or not, is looking at the body of the population as a whole. I mean, one of the concerns right now is, is any given family better off today than they were, or they were 5 years ago? And as Lindsay's numbers pointed to, their costs are actually higher now. What we don't know is what would they have been if this hadn't happened. If we take into consideration the direction and the trends that the numbers were going anyway, if we add on to that the aging population of the baby boomers, there was really some pretty apocryphal literature that was coming out of trusted peer-reviewed journals that were saying we're going to break the system if something is not done. And that's, of course, something we don't know. But the numbers that are coming out that Lindsay's referring to are current, and as current as we can get them. That doesn't mean that 2015, when it closes out, won't show us something slightly different, because there are
right.
loopholes in this program. So one of the things Lindsay, you and I you can jump right in here, because something she and I did was we're trying to get the most recent numbers and statements we could. So we're listening to shows by the Diane Rehm Show. So we're tuning into NPR, and if any of you want to know what some of these references are, please just drop us a note. We'll share with you the things that we searched out and listened to. And it was about 10 days ago, there was a show on Diane Rehm that had a policymaker from Washington and somebody from an agency. There were 3 experts who were taking calls in, and there were some pretty amazing calls. And one of the callers pointed out that there is a loophole in the law, so that to qualify for a supplement, the bar is set around an individual. So if an individual makes a certain amount and their health care costs would be a particular amount, they can or cannot possibly qualify. What the bar does not look at is what happens if they're trying to insure their family. So the caller who called in actually gave a scenario where his wife is a teacher in Texas, and he lost his job. They have 2 little kids, and they cannot afford to insure their family, because even though her health insurance premium is pretty reasonable, to insure the entire family would be about half of her take-home pay. And when they attempted to see what could be done to remedy this, somebody who they spoke to at an agency actually said they could consider divorce. Well, that, of course, is going to become an apocryphal sort of story, and it's going to make the NPR headlines. But what we don't have are numbers yet from 2015. And that's going to also indicate what has happened with the insurance companies. There is no cap on what insurance companies can charge and increase premiums. So that could be a way where people do experience a higher cost. But again, I take you back to the first point. We don't know what would have happened without this. Other questions coming in on that? Yeah, Lindsay, go ahead. Your turn.
Oh, I was just going to add one small point to that, which is something you mentioned earlier about sharing the cost and having that shift to the individual a little bit more. One thing I noticed personally is in Texas, they've now done away with all of the PPO options on the exchange for 2016. Now it's all mostly HMO and EPO, which I believe is exclusive provider organization. And I think that's an interesting shift as well. As we see this developing over time, you know, everything is going to change, I think, year by year. How this actually gets implemented, what the options are, what states are doing. You know, for me that was kind of a disappointment, because I don't really want to be on an HMO, but at least there are options with the minimum essential coverage still available, and that they're decently priced versus what I would get privately anyway. But this is another point to add.
So where we come into this course that we did this work for is from the standpoint of looking at the entire healthcare system in the United States. And I'm going to go back to that for just a moment before I would then move into my portion of the presentation again. But I want to thank Lindsay, too, for the wonderful job that you did, the really good scholarship and research you did around this. And there are a couple places where you enlightened me, and I wanted to jump right in, but you have such a good presentation going here. I didn't want to interrupt the flow. I do want to point out, though, that when the CDC or the Census Bureau or or Forbes asks a question and then we create a chart from that, remember that many of the people who are on this call tonight are also researchers or budding researchers. So much of it has to do with the way you phrase a question. So right. When we're looking at poll data and survey data, and this has been a huge criticism that I've heard in some of the political arenas and debates right now, is I've heard some politicians or candidates actually say, well, the numbers are shifting because they're changing the way they ask the question. Well, they asked the question a different way before, so I don't know what exactly there has been normalized. But keep in mind that data is not perfect. The data, for example, coming out of the Federal Budget Office looks at the cost savings that are attached to the outcome with the Affordable Health Care Act, and you can look that up if you go to the budget numbers. And also I have some lists of references, and we can post both these PowerPoint presentations in the healthcare systems area in the mentoring center. But back to the budget office, one of the biggest sources of reductions in the deficit, which is what's happening, what's associated with the Affordable Health Care Act, is coming from collection of fines and fees that have to do with noncompliance and individual noncompliance. Well, obviously that's not going to help anybody's well-being, but it does help the national budget. So there are many different factors at play here, which is why to us it made a lot of sense to look at it from a systems perspective. One more thing I want to say about the systems perspective overall, and it's something we address in the course, is that there is an ideology or philosophy that is behind the U.S. healthcare system. And it starts in the very beginning with the pioneering spirit that made America great, and I'm putting quotes around that, but it is a major consideration. And the books that we use, the textbooks that we use, address that explicitly, that there is a philosophy that underlies the way that we develop policy and that we look at healthcare in this country. It is a commodity that is offered as a for-profit service and product on the open marketplace, which is much different than those countries that we're being compared to on the chart that Lindsay showed us earlier, treat healthcare, where in many places healthcare is a utility and it is a service, much like we would be getting water or electricity. So, Lindsay, anything else you want to add to that?
No, I mean, I think that's all really valid points. I especially like the point about the data collection. You know, it's hard to know exactly how to compare historical results to today's surveys and that kind of thing. And I think people are attempting it. Like, I pulled all these graphs from various places, and but it's always good to remember that this is subjective to some degree. So I appreciate that.
Great. So, Don, do we have any questions before I lapsed into the last lap of this presentation?
Yes, just a moment. Oh,
okay.
Ruth Ann Russo thanking you. Let me see if there's anything else. Okay, that's it.
Okay. I'm going to switch on over then, and I've taken down the screen while I fumble around between my presentation and put it back on slideshow so we can see. Let me catch myself up here to, okay. Okie dokie. Where I want to pick up right now is that what does this mean to us as integrative practitioners or practitioners of integrative medicine and wellness? And Don, can you see my screen right now?
Yes.
Excellent. Good.
Yeah, and the slide is filling.
Big.
Yeah, exactly.
Okay. Okay. So there are a few major overarching points I want to make. But as I left off before, with the Affordable Health Care Act, we're looking at a national policy. We're looking at a policy, a regulation, a law of the land that applies to us across all 50 states and territories. But healthcare in this country is not conventionally and traditionally governed on that level. Policies tend to be guidelines, and with the exception of Medicare and Medicaid, which are relatively new introduction to the U.S. healthcare scene, healthcare service delivery on a federal level has remained unregulated on that nationwide basis. And there are a couple philosophical points behind that. One is the idea that health care to the American, to the average American, I'm not saying this is true or not, but it's part of the mythos that shows up in the textbooks, that health care is a very private experience and should be between a person and their physician. The other part that shows up is that the regulation or the nationalization, national medicine, would actually reduce the quality of the greatest healthcare system in the world. And I think the numbers that Lindsay showed us actually draw attention to the fact that what exactly is the greatest healthcare system in the world. I want to leap forward with this next part, though. And that is to point out that on a federal level, the federal government, federal policies, regulate very little about service delivery of health care. And some of you are going to say, well, that's not possible, because I know I'm terribly regulated. I'm over-regulated, maybe. I'm regulated from the left and right as a practitioner. And I don't doubt that whatsoever, but I'm going to point out that that is done on a local level. So your license as a practitioner comes from your state, your county, maybe even a smaller jurisdiction than that. Your scope of practice is set by regulations that occur on a local level. Who gets to practice what is actually done on a local level. So what about the Affordable Care Act could possibly make any difference to us as integrative practitioners? Because a whole other conversation around this is there a battle of scope of practice going on between the integrative practitioner and the conventional provider of healthcare services? And as I say, that's probably way beyond the scope of this presentation. What I want to do is point out the provisions in the Affordable Care Act that provide limited windows of opportunity. These are not huge portals, but they are cracks in the way the system operates. And I don't mean cracks in a bad way. I mean that they are open windows of opportunity. What exactly happens with them remains to be seen. In my very last slide here is to recap some of the things we've seen in the last year that indicate that there are some shifts that are afoot. So first of all, some highlights. Based on integrative medicine and wellness, the Affordable Care Act offers a non-discrimination clause for complementary and integrative practitioner services and their approaches. This portion of the law was actually modeled after a provision that occurs in Washington State and has been in place there for over a decade. And we actually have good return on investment data that's based on what has been going on in Washington State for that period of time. I'm going to show you where the provision on that is in the Affordable Care Act in just a moment. The other possible opportunity has to do with integrative healthcare facilities and programs, and that has to do with the offering of programs, facilities, and opportunities for community healthcare organizations and services. And we probably all have some really interesting stories around that, but I'll be mindful of time. The third opportunity, which I think is considerable, has to do with workplace wellness. And initially, there was a lot of excitement around that. I know Ruth Ann Rousseau was on the call earlier. She did some wonderful research around workplace wellness in conjunction with her dissertation work for her doctorate in MBM. And basically summarized says that employers can get tax credits for offering programs within their workplace. There also is the provision for community health care centers, and then finally one about behavioral health, providing options beyond what are simply pharmaceuticals. So there are signs. Oh, did I miss something here? There we go. I did. I missed some of my, here we go. I jumped too far ahead. So sorry. All right. Opportunities generally for the integrative medicine and wellness offerings are to focus on chronic conditions, expanding offerings to address prevention within conventional or traditional systems, opportunities for education and coordination through certified healthcare wellness coaches. And there have been some studies done on that show overwhelmingly that the introduction of the healthcare wellness coach can shift the return on investment for a preventative program. And if anybody's interested in some of those references, again, you can let us know. We'll post our resources. The other opportunity is a bigger one, and this is not going to occur within the next year or two or even decade. But as some have said, the Affordable Health Care Act has already changed the landscape of the American healthcare scene. The train has left the station. So that has occurred by shifting awareness from illness onto wellness. And that occurs in a variety of different provisions. Also the shift to individual responsibility, and something that we talk about in a variety of our classes in our programs that go beyond those in healthcare systems is shifting awareness on an individual level. That maybe touching really is the real revolution, that getting one individual to change their mindfulness will begin with changing their sense of responsibility about their own health care, their own wellness, their own prevention. The provisions specifically in the Affordable Care Act that provide opportunities are these. In Section 1201, that is the workplace wellness activity provision, and that allows for employers with employees of over 50 or more, and I know that guideline is going to change about some things in the coming year, but as far as workplace wellness activities go, those larger concerns can get tax credits back for introducing programs within the workplace that are evidence-based. And that's the key here. The programs need to be evidence-based. But if you've been following what's going on in the workplace in a variety of different scenes, you might have heard about the program at Google to introduce mindfulness meditation to the workplace. Well, we're all part of that. We know from our own training in MBM that we do have evidence to demonstrate the efficacy of mindfulness-based stress reduction and the effect that that can have on overall wellness. For offering those sorts of programs, employers get incentives back. One of the things that's been surprising about that, though, over the last couple of years is that employees are not taking advantage of these programs in the droves that we thought they were. And there is still some question around why that's occurring. You might read Ruth Ann Rousseau's dissertation for more insight on that if you're interested in that particular topic. The next section I want to point out is that Section 3502 establishes grants for medical homes and includes complementary integrative medicine practitioners. I really do encourage you to look at the PCORI website. As Lindsay mentioned earlier, PCORI is about patient-centered resources or research around investing resources into what services can make a difference for people, but also and they do fund research. In looking at the research grants that have come out of there in their guidelines, I have been discouraged by some of the possibilities with my own students because they tend to be very medically based in their guidelines. However, I'm also encouraged by the community grants that are available, and you could be working on something in your community right now that might qualify for a grant. So consider taking our grant writing class and starting to scroll through the landscape to see what opportunities might exist. And as go federal funding, oftentimes you'll find matching grants from private sectors such as the Robert Woods Foundation, and there are other places that are offering private grant monies for integrative practitioners. Third thing is in Section 4001, and that is back to the National Prevention, Health Promotion, and Public Health Council, which is an advisory group on prevention, health promotion, and integrative public health issues. And there was some concern about this because this section established a council and then did not fund it. So it was an organization that had some responsibility and no authority because it didn't have any budget behind that. Hopefully that will shift in the time ahead, but I've got a point that I'll make about that at the very end. And also I am mindful of our time, so I'm going to go sort of quickly, point out that Section 4206 creates a pilot program for at-risk individuals in community health centers. There are some really interesting things going on there in a community level. I was visiting my daughter in Portland a couple weeks ago, and there I stay with in an urban farm, and they have carved a relationship with their community health center up the street, and they are teaching people who come in for community health services how to grow their own vegetables in their urban farm. So this is another place where there is some innovation and creativity going on, and one of the things that complexity theory does tell us is people start talking to each other and they're given opportunities to get creative, that innovation then has a possibility to become one of those butterflies. The next one is Section 5101, which creates a National Healthcare Workforce Commission, and that includes complementary and alternative professionals as healthcare practitioners. This becomes very important. I'm going to point this out on my next slide, and then the following talks about PCORI. Section 2706, very important. This is modeled after the law that's in the state of Washington. It's non-discrimination in healthcare. This requires that any insurers who insure healthcare services include and reimburse licensed healthcare providers that are licensed according to their state law. So two critical things here. Number one is licensed healthcare providers, which means that if you are a massage therapist, an acupuncturist, a chiropractor, you are licensed according to your state law, that you cannot be discriminated against by insurers in that state because that state has authorized you to be a healthcare provider. Now, a tricky part about that is insurers can decide how to vary the reimbursement. All the law says is that complementary practitioners will be covered. It doesn't say which procedures are covered or how much they're going to be covered for. Also, insurers don't have to offer in-network for every complementary provider, but just enough to serve a population. And exactly what the rules are around that are still to be determined. I've also heard some things on NPR, and I can't find any data on it, that there are many instances of noncompliance where states are not actually following through with that on their local level. And one of the shows I listened to had to do with mental health care providers not being covered under this when the law of the land would have them covered. So maybe some of you on this call know something about this, and we could continue this conversation somehow in a forum. The non-discrimination provision does provide an opportunity to create access, but it does not mandate it. And that's the difference. That's why this is a limited window of opportunity. So far, it really hasn't seemed to make much difference, and that's the point about insurers not being compliant. So I'd already told you about this, I think. Here we go. This is what I did a little searching, and this is what the pundits are saying right now. So if I scanned all the articles that were in the news media, so this is not evidence-based, this is not peer-reviewed, this was Luann scouring the internet in New York Times, and these are the points that I found as of today that we should be paying attention to. There are signs that complementary integrative medicine is rising, and that might be indicated by my second point right here. In January of this year, the NIH changed the National Commission for Complementary and Alternative Medicine to the National Council for Complementary and Integrative Health. There's a lot to be said in the name. So integrative health is now demonstrating that this is part of the convention of offering healthcare services to the people in the United States. The point right above that, the Joint Commission is important because they accredit locations that offer that are accredited to offer healthcare services, and they promote integrative pain care in accreditation priorities. So if they're evaluating a facility, be it a nursing home or be it a rehab center, that they're taking an equal look now on their checklist to see if integrative services are offered in conjunction with pharmaceuticals and the more traditional treatments. The third point is maybe not good news for integrative practitioners, and it has to do with a political shift. The funding for all of these programs we're talking about depends a lot on the Senate Appropriations Committee. It has moved from the likes of Bernie Sanders to Shelby, who's a Republican from Alabama. And the indications are that there will not be as much political support under this domain for integrative practices. Of course, it remains to be seen. Because on the other hand, we have popular support rising, and there are complementary integrative medicine stars out there. We see a lot in the press about places like the Cleveland Clinic, but we have our own stars here in our own program. And I encourage you to check out the MBM blog to see exactly what some of our stars are doing. In fact, I can jump ahead a couple bullet points to mention that the Veterans Health Administration has initiated an Integrative Health Coordinating Council and dedicated $22 million for that purpose. I'll back up a little bit and point to the Academy of Integrated Health and Medicine, which is gaining some momentum as an organization of members, of member-governed organization promoting integrative health practitioners, and I believe some of you participate in that, have attended those conferences, possibly are members. Indications that we are shifting to a culture of health. The data shows that there is less childhood obesity, and it's going around in conjunction with changes in the dietary programs that we're offering our kids in schools. There is an increase in workplace wellness programs, and the idea that mindfulness is no longer something that is in the corner and just attached to a particular faction of the population. One thing I'd like to point out, and I know I don't have much time left, is the maturation of massage therapy profession, I think, is important. There are an estimated 375,000 practitioners of integrative medicine who are covered under one of the major organizations that is consolidated under the last bullet point, the Academic Consortium for Complementary and Alternative Care Practitioners. Of those 375 practitioners, over 250,000 of them are massage therapists. And the massage therapy industry and field can show a maturation of integrative healthcare practitioners that can be modeled by others who are looking for ways to standardize and have norms that apply across the U.S. And I'd also like to make a plug for the Society of Integrative Oncology. I actually review for their journal, but they are definitely promoting different practices and research that's going on today. So, Don, at this point I realize that I have exhausted my time and we've probably worn everybody out, and I want to see if there are any other questions out there.
There are, and I want to first, before I go to the question, I do want to thank both Lindsay and Luann for a thought-provoking presentation, certainly a controversial area where we have to continue to watch the trends as they unfold. Here's a comment. Thank you, Lindsay and Luann, for an amazing presentation. Could you please post the references related to health coaches and return on investment?
Absolutely. In fact, there goes my slides. I have some on my slides. I will post the presentation, and I assume, Lindsay, that's going to be okay with you too, right? We can get this up into...
Oh, yeah, sure.
Great. We'll get this up into the Mentoring Center where there is a module for healthcare systems, and so you'll have these references as well as in the part of the presentation, Lindsay's presentation you didn't see, the underneath part, the notes, are all of the websites and the locations that she referred to. So
okay.
You'll be able to see those.
Here's a comment from Carolyn Trasco. This section 2706 seems similar to mental health parity laws, and it took a long time for insurers to come into compliance. When some of these insurance companies did come into compliance, they carved out mental health services to other companies that pay lower rate for services, required more hoops for mental health providers to jump through, and so on. Sometimes what is beneficial for patients, increased access to care, does not always benefit the provider level because insurance companies do not really want to have to put monies out for these types of services.
And I'd like to respond to that briefly by saying my concern for that goes even deeper, and the research that I've done with massage therapists speaks to this, because what I saw in the state of Washington, where we had the law that I referred back to before the Affordable Health Care Act. So massage therapy as a service has been covered in the state of Washington for some time. There are studies that show the return on investment has not cost the insurance companies anymore. There are studies that show that because of it, massage therapy does proliferate in the state of Washington, but the nature of massage therapy has changed there. And I think not necessarily to the worst. It certainly became more medicalized, but I think something we have to pay attention to as practitioners is to hold the integrity of our paradigms, so that the danger is that the services that we provide will simply become slotted into available places on the menu or the service for the insurance form, and we substitute massage for physical therapy. We substitute acupuncture for STIM. We substitute different things, but we don't shift the paradigm. It's very dangerous. The responsibility for maintaining the integrity of what we do lies with the practitioners. And I'm not trying to be insensitive to what mental health care practitioners have struggled with, because I think in some places we walk a line between, is it important to get our services out to a population that otherwise would not be receiving them at all, and at what point do we hold on to the philosophy, which makes us much more expensive? I'm going to stop.
Okay, thank you, Luann. Thank you, Lindsay. Several comments in the question box just thanking you, Innocence Branch, Kanishka Agarwal, thanking you for the program. So we will have access to the PowerPoints. That's helpful because there are a lot of useful references, and I'm glad that you all were able to be present this evening. I'm going to stop the recording, and this will be available for follow-up for anyone who wants to see it again at a later time.
Don, thank you.